Now in this module we will be seeing something on type 1 diabetics. When it comes to type 1 diabetes, insulin pumps really scores. So we are not going to see about insulin pump, how to manage your type 1 diabetic patients in a pure professional way. That is what we are going to discuss in this session. The principles that guide the insulin pump, how can we stimulate all those principles in real life and manage the patients in a better way. That is the objective of this module. So we'll be seeing exactly 5 points on this, which are essential for the management of type 1 diabetic. This is the objective of this module. So we'll just, for the discussion sake, we'll just take a much complicated case. Mr. Sam, he is 31 years old, 70 kgs. He is type 1 diabetic for the past 6 years. He is on co-formulation. When we mean by co-formulation, it is about a long-acting insulin, which comes in the name of Ryzodec, which is the costliest insulin available as of now in the market. So the co-formulations, which is a long-acting insulin with a short-acting analog. This long-acting insulin has got a ultra long-acting, means it can act for even more than 24 hours. And the short-acting insulin aspart, which can take care of the meal stimulation, meal stimulated glucose increase. So he is on the mixture of these two insulin, which he is taking twice a day for the comfort. So he is about 38 units in the morning and 24 units he is taking, and his HbA1c is about 10.1. So this brief summary will suffice for discussing this patient. We will not get into the other details. We are going to deal about how to manage this patient's blood sugar very comfortably. So as we see, this co-formulations, as I said, it is a mixture of long-acting insulin and a short-acting insulin. So both these are all analog, and this long-acting insulin will act for more than 24 hours, which gives a benefit. And this short-acting insulin acts for, these are all the aspart. We discussed about aspart in the previous module. So these will take care of the meal, and he is not taking anything for the lunch. So what we want you to know from this is, so as we see, the blood sugar of the individual didn't get controlled at all. So if you see, like his HbA1c is about 10.1. We are using a costlier insulin which is available in the market, but in spite of it, his blood sugar is not getting controlled. Now for this individual, so if you try to increase the long-acting insulin or a short-acting insulin, what will happen is, so this is a premix insulin. This is a premix insulin. So what will happen is, this is what his glycemic excursions are. These are the glycemic excursions, and this is a long-acting insulin profile, and a short-acting insulin which is acting over there. So this, what actually happens to these individuals when they are on this mixture of a short-acting and a long-acting insulin is, so when we try to control the overall day or the basal requirement with a long-acting insulin, so since it is in a combination of 30-70, this is not pre-mixed, this is called as co-formulation. Rather than calling it as a pre-mixed insulin aspart, this is called as co-formulation. Or we can use this type of insulin also. We can use a pre-mixed insulin, where the pre-mixed insulin, what we mean by pre-mixed insulin is, the 30 parts will be a short-acting insulin analog and 70 parts will be the NPH insulin. Whereas here the long-acting insulin will be degludec. So that is a long-acting insulin. Short-acting insulin, both the formulations is going to be the aspart insulin. Now, when we try to take care of the long-acting insulin, when we try to increase the long-acting insulin to take care of the basal part, when the fasting is not getting controlled, automatically we are increasing the short-acting insulin also, whereby the patients will be more prone for hypoglycemia. So this is the disadvantage. So why? Because this part we are trying to increase, automatically this part also will increase. So the patients might be prone for hypoglycemia because of this fixed formulation. Now, in case if his meal stimulated insulin is higher, we may be trying to increase the dose of this insulin. So this part we are trying to insulin. So automatically this part also will increase. So whereby it will cause, and again, hypoglycemia. So it doesn't give the balance. So when we try to increase this, this is also we are indirectly increasing the short-acting insulin, predisposing the individual to hypoglycemia. when the meal sugars are not getting controlled, when we try to increase the short-acting insulin, the long-acting insulin dose also automatically, because of the premix nature, it gets increased, and that predisposes them to hypoglycemia. So this doesn't give the flexibility of addressing the hyperglycemia without causing an undue hypoglycemia. So the first tip that we need to know as far the type 1 diabetic patients are concerned is the premix insulins or co-formulations, as we discussed, deliver a fixed dose of basal and prandial insulin. They are not a flexible regimen. When we mean by type 1 diabetic, even though these co-formulations are costlier, the basal bolus regimens are the preferred regimens for our patient. So when we mean by basal insulin, this basal insulin could be your NPH, this basal insulin could be your glargine, or the basal insulin could be the degludec. So that is what we mean by basal. This bolus insulin is the prandial insulin. It could be the short-acting Trapid, or the newer ultra short-acting analogs, 3 insulins are there. So they can be the bolus insulin. So this is the first point that we need to know. We have to give it in a split way, whereby the basal insulin is given when we give it as a NPH. NPH has to be given 2 times a day. Rather, this long-acting insulin like degludec and glargine can be given once a day. So the first mantra or the first principle understanding that we need to have in these patients is, it is about basal bolus regimen, 1 basal insulin or 2 basal insulin when we give NPH, and 3 prandial or 4 prandial insulin based on the snacks that the patient is taking. So it should be basal and bolus regimen is the one that we need to give for our patients. So that is the first lesson that we need to know. The second thing is, when we talk about the management of diabetes in type 2 diabetes, we looked into this formula of blood sugar, the target blood sugar or the blood sugar fasting minus 100 divided by 10. That is the formula we looked into, how the dose is being calculated. But when it comes to type 1 DM, the patients might be just 5 years old, the patient might be 3 years old, the patient might be, as we see in our gentleman, the patient is much more, he has crossed his adolescent and he is there. So a single regimen will not work in all our patients. So that is the very, very important thing. So here what we do is we calculate the insulin dose based on the kilogram of the individual, because our patient might be just 5 kgs. Our patient might be 50 to 70 kgs also, or 100 kgs also. So it is per kg dose is the one which we need to adopt. So the basal dose of insulin requirement for most of our patients, the total daily insulin dose is about 0.5 into body weight into kgs, of which 0.1 to 0.2 will be the basal insulin, the rest all will be the prandial insulin. This requirement can be even from 0.4 to 1 units per kg. Insulin gets secreted at the rate of 1 unit per kg in our body. So this insulin requirement can go even up to 1 unit per kg per day, or in an occasional case, it can go up to even 2 units per kg. So this is the total insulin dose which the patient requires. Of this requirement, 50% has to be basal insulin and the 50% has to be prandial insulin. That is how we have to know. So if the patient requires 70 kgs, if the patient requires 35 units of insulin based on this calculation, so he requires about 35 units, of which 17 units should be basal and the rest all 17 or 18 units should be prandial, which has to be divided into 3. Like say if you take it as 18 units, so he has to take 6 units with breakfast, 6 units with lunch and 6 units with the dinner. So this is how the dose calculation is done, and 17 units as the basal insulin. So this is how we arrive at the calculation. So for our patient Sam, he is about 70 kgs. He needs about 35 to 70 units. 35 to 70 units based on the 0.5 to 1 units. Already he is getting about 62 units. How did we arrive at this 62 units? He was taking 38-24 units of co-formulation. So he is taking about 62 units already he is getting. So this we have to mix and match, because the patient, we cannot go only with 0.5 units. It is more than the requirement. So 62 units he is getting now basal bolus. Now the thing is, One important principle that we need to know is, like here we have divided this 17 or 18 units into 666 3 times a day. What actually happens in most of our diabetic, even type 1 diabetic or type 2 diabetic, is there is an early morning surge of the blood sugar, the dawn phenomenon which happens. So because of the cortisol and growth hormone which are getting secreted over here, early in the morning, generally the blood sugar is slightly elevated than the other part of the day. So the mantra that we need to know here is, with the lunch, the prandial requirement will be slightly lower. It could be just 4 units. Rather, the breakfast requirement will be slightly higher, is the one which most of our patients will need. So it should be like, the point that we are conveying at this point of time is, the prandial insulin dose is, the requirement is slightly higher because of the dawn phenomenon. As you see, the rest of the day, so post lunch, post dinner, everything, the sugar levels comes down. Whereas if you see the early morning surge around 4 to 6 a.m. or 7 a.m., there will be a peak in the blood sugar level which happens. So if you see at midnight, the blood sugar will be around say 100 or 130 or 140 at 12 o'clock, 3 o'clock. But as you see, as he wakes up, the blood sugar might be 150, 160, 170. There might be a slightly upsurge. Even it may go to 180, 200. Some patients may encounter this. So we need to understand there will be an early morning surge. So the point that we need to know over here is, so we should not be keep taking only the basal insulin to control the fasting blood sugar. So what will happen if you try to address only the basal insulin by increasing the dose of basal insulin? What will happen? The patient might be pushed for nocturnal hypoglycemia. So we need to know whether this surge, early morning surge, is happening in our patient, and if it is so, we have to address that by giving a short acting insulin, or we should avoid increasing the basal insulin dose, whereby we might be pushing the patients to hypoglycemia. So this is very, very important for us to understand that this early morning surge happens. So as we said, the insulin dosing, so we have to calculate the insulin requirement, which is about 0.5 to 1 unit per kg, and the insulin, 50% of it has to go as the basal insulin, and 50% of it has to get converted to the prandial insulin. Of the prandial insulin, the breakfast requirement will be slightly higher than the lunch dose. So due to dawn phenomenon, the prandial insulin dose with breakfast is higher than the other time of the day. So this is the second point that we need to know. Okay, so in our patient, as you see, the glargine, we try to convert it into basal bolus regimen. So the basal bolus regimen, he was taking about 24 units of glargine, Sam is taking, and he is taking about 18 units in the morning, 5 units with the lunch, and 10 units with the dinner. So this is not what we actually taught you 5 minutes back. So it has to be divided equally. But the patient requirement or the patient's response to each meal may differ. So we need to assess each individuals in a different way. So this is the message that we want to convey. So the rough formula is to know how the patient responds, or when we want to initiate the insulin. But as we see the control, we have to adjust for the each meal. So the 7-point blood sugar becomes very, very important. So you need to have a one fasting insulin, and before breakfast, before lunch, before dinner 3 times, and after breakfast, after lunch, after dinners, and other than that, there should be, we have to have a 3 a.m. blood sugar also to see whether the patient is going for a nocturnal hypoglycemia. So before breakfast, before lunch, after lunch, before dinner, after dinner, and 3 a.m. we need to have. So with this 7-point blood sugars, we may be able to manage our patients. So here, as you see, Sam, the fasting blood sugar is about 130. But post breakfast it is higher, post lunch it is higher, post dinner it is higher. So but when we increase more than this, what our patient Sam was telling was, he is getting hypoglycemia. So when we increase the dose of actrapid, the patient is getting hypoglycemia. So what could be the reason? How to address? Is it right to leave the patient at this hikes, so 326, 360, it is quite high, but fasting is still, it is okay. 130 is still okay. We can reduce it slightly further, but the meal related excursions are very high with Actrapid or meal related insulin. So what actually happens is Actrapid actually doesn't exactly mimic the glycemic excursions that happens in our body, because Actrapid typically lasts 4 to 6 hours. It peaks at 4 to 6 hours, and the effect of it can last even up to 6 to 8 hours. So the short acting insulin Actrapid, it peaks between 4 and 6 hours. The action of it lasts up to 6 to 8 hours. Whereby if we try to give this Actrapid, this short acting insulins, or the regular insulins, what will happen is the insulin keeps acting even for 6 to 8 hours, and that may predispose to hypoglycemia in our patients. So what is important that we need to know is, so as we see in this chart, this is just stimulated to make you understand the regular insulin acts like this, whereas the meal related glycemic excursions are as shown over here. So this short acting insulin the regular insulin, the short acting insulins may produce hypoglycemia at this point of time because of their extended nature. So what we need to know in our patients, especially type 1 diabetic patient, is instead of these regular insulins, we have to switch over them to ultra short acting insulins, as we had shown over here. So we have 3 ultra short acting insulins. We can go for Aspart or Apidra or Lispro. So these ultra short acting insulins closely mimic what is happening in the body. As you see over here, it closely mimic. Even that may be predisposed to slight amount of hypoglycemia, but definitely far less than what is happening with the regular acting insulin. So the point which is very, very important is this analog ultra short acting insulin. So short acting insulin is the regular insulin. Ultra short acting insulin is the Aspart, Lispro or Apidra. So these analog ultra short acting insulins are better than the conventional regular insulins. So especially when it comes to type 1 diabetic, elderly and pregnancy, we have very clear recommendations for this ultra short acting insulins than regular insulins in our patients. So that makes the third point that we need to know. The regular insulins are not the insulins of choice for a type 1 diabetic patient. It should be the ultra short acting analogs which should be preferably given for our patients. Now, Sam. Our Sam is an IT professional. So he takes dinner at office, and he says that he cannot refuse team lunch, which happens over the weekends. But at the same time, like, we have moved over to the ultra short acting analogs now. So it can be replaced 1-to-1. So we have given about 18 units of in the morning ultra short acting, 5 units in the lunch and 10 units at night, and his glargine dose is 24 units. So the fasting is 130. The post breakfast continues to be 300 plus. Earlier also, before ultra short acting, it was about 300 plus. And post lunch it is again 300 plus. What he says is any units more than this causes symptomatic hypoglycemia. So we said, like, ultra short acting insulin should take care of the meal related hypoglycemia. So, but in spite of even switching over to ultra short acting insulin, he says that still he is getting hypoglycemia. But what he says apart from that is, he says that there are good days and there are bad days too. So what does he mean by good days and bad days? He is able to typically see on few days of the week, he is able to see the glycemic excursions are good without hypoglycemia. And he says that there are bad days where he gets hypoglycemia or where the glycemic excursions are very, very high. Now, these are the patients when such fluctuations are there, they are ideally suited for pump, but he refuses pump because of his cost constraint. In Indian money, the pump may cost about 4 to 8 lakhs, and per month it costs about 25,000. So he has his own reservations. Then he says that he is not affordable, or he doesn't want to use pump, and he refuses to do the self-monitoring of blood glucose on working days also. So whatever is happening, so it is all on the weekend. So what happens in the weekend? He is having team lunch. So he is checking the blood sugars on the weekend. On the office days, he is not checking. But when he goes for team lunch or when he goes for outside, still he is able to manage on those days. So what is happening is, on those days when he is taking food outside, his glycemic excursions are higher than what happens during a typical office day. So where he says, like, it might be good also. So we are not able to tell Sam like, yes, go with this insulin, it will work on all given days. So some sort of rationalization has to be taken in the way he's taking the insulin, because it is not working on the weekends, but probably it may be working on the weekdays. So that is what our understanding at this point of time. So in the weekends, when he says, when he goes for the team lunch, probably he might be ending up eating more amount of carbohydrates. So that is the reason why his blood sugar is more. So how do we address this increase in the carbohydrate intake or carbohydrate consumption that happens over the weekend? So that is our question. So the bolus, when we mean by the bolus or the prandial insulin, it is all covering the carbohydrate coverage. That is what we have understood. So the prandial insulins are given 3 times a day to cover the carbohydrate coverage. Most of the prandial blood glucose increase is due to the carbohydrate content in the meal. The insulin to carbohydrate ratio is something which represents how many grams of carbohydrate are covered or disposed by 1 units of insulin. So what we mean by that is, we can ask Sam to calculate how many units of carbohydrates he is consuming on the weekend. So based on that, we can give or adjust the dose of insulin. He can just see like what he is consuming, and based on that he can take like whether he wants to take 18 units or 20 units or 16 units. Based on that he can adjust his dose of insulin. That is what that we need to empower in our patients. So Sam needs that sort of rationalization, because it might be working good on these weekdays, and weekends, say if he is consuming more, he has to increase the intake of the insulin. So that is addressed by this insulin carbohydrate ratio. So 1 unit of rapid acting insulin will dispose of ideally 12 to 15 grams of carbohydrate. This is a thumb rule, but it will not work for all the patients. So it might vary. This insulin carbohydrate may vary from 4 to 30 grams of or more of carbohydrate also, depending on the sensitivity of the individual. So what we mean to say is, generally when we give 1 unit of insulin, we anticipate it will take care of 12 to 15 grams of carbohydrate, but it can vary between 4 to 30 grams also. So we will add more clarity in the further slides. So what we need to know is, insulin carbohydrate ratio is something like which we need to know for that particular patient. We will tell you how to derive for that patient. So whereby that 1 unit of insulin will take care of that many grams of carbohydrate. So how to arrive at for Sam, like how do we know like how many units of insulin will he be needing? So before calculating that, some patients may require a different insulin carbohydrate ratio at one of their daily meals, such as for some people, say for breakfast, typically the insulin carbohydrate ratio may be 1:10, but for lunch and dinner it might be 1:15 or 20. It means that 1 unit will take for the breakfast about 10 gram of carbohydrate, but at the same time for lunch 1 unit of insulin will take care of 15 grams of carbohydrate. So it may vary for patients also. It may vary from 12 to 15 or 4 to 30, or it can be varying for the breakfast. Typically, like for breakfast, his insulin carbohydrate ratio might be 1:10, whereas for lunch and dinner, it might be 1:15. For some, it might be 1:5. So 1 unit may be required for 5 grams of carbohydrate, whereas for lunch, it might be 1:20. So 1 unit will take care of about 20 grams of carbohydrate. So a variation like this can happen. So for meals that include a large amount of fat, glucose availability will be delayed. So if he is going to take some amount of fat, it will prevent the absorption of carbohydrate. So if it contains the fat, so that also will retard the absorption of glucose in our patient. So how to calculate this insulin carbohydrate ratio? So the formula is very, very simple. How many units Sam was taking? He was taking about 62 units of insulin. And that is the amount of insulin he was taking. So 500 divided by 62, approximately we will put it as 60. So for Sam, it is about 8. What is this 8? 8 is insulin carbohydrate ratio. So insulin carbohydrate ratio of 8 for Sam means, so 1 unit of insulin will take care of 8 grams of carbohydrate. So that is what we need to know. Very, very simple. For Sam, if he is going to take 100 grams of food, then he will require about 15, it is about 12.5 units of insulin. So if he is going to take 200 grams of carbohydrate, for breakfast. So that is not what we advise our patients. His carbohydrate should be anywhere between 130 to 150. So if he is going to take about 200 grams of carbohydrate, then how much amount of insulin he will need? He will need 25 units of insulin. So this also may vary between breakfast and lunch and dinner. So that is also we need to know. So approximately we will understand what is an insulin carbohydrate ratio. Insulin carbohydrate ratio is how many 1 unit of insulin will take care of how many grams of carbohydrate. So in Sam case, how do we arrive at it? There is a fixed number. It is always the numerator should be 500 divided by how many units he is taking. How many units of insulin he is taking currently. So 500 divided by 60, it is about 8. So 1 unit of insulin will take care of 8 grams of carbohydrate. Fine. So now if Sam is going to, as I said earlier, if Sam is going to take extra like 100 grams of chicken, all that he will need is extra 1 unit of insulin, isn't it? Say for chicken biryani, we have calculated we know how much he is going to take insulin. It is about 12.5. So in case if he is going to take extra 100 grams of chicken 65, he will need for this 8 grams of carbohydrate. 100 grams of chicken gives about 8 grams of carbohydrate. All that he will need is only 1 unit. So 13.5 is the one that he needs to take. Suppose if he is going to take about 50 grams of extra biryani, then you have to add 12.5 plus 6.25 plus if he is going to take chicken, it is 1 unit. If he is going to take double the amount of chicken, he has to take 2 units. So like that, he has to calculate what he has to take for that meal. So for 50 grams of rice at home, he was taking just 5 to 6 units of insulin. That was working well. But if he is going to take 100 grams of biryani, so Sam's lunch insulin was about 5 units if you remember. So it was looking good. But in case if he is going to take biryani with chicken, how many units he requires? He requires about 13.5 units of insulin. Now we will come to slightly more carbohydratic food. So for breakfast, 30 grams of idli. Chutney is about 100 grams of chutney has about 18 gram, 100 grams of sambar has about 10 grams of carbohydrate, and vada is about 40 gram. So in case if he is going to consume more, we can calculate for this how much he requires. So for Sam, the insulin carbohydrate ratio is 8. So what is it comes about 100 grams. So how much insulin he will require? He will again require 12.5 units of insulin he will require for this food. But as we said, for breakfast, it may be higher also. Remember that. Having said that, now, in case if he is going to take one more idli extra, so here he has taken 3 idli. If he is going to take 4 idlis, then his insulin requirement will be 4 units extra. Why? 30 by 8 is 4. So he will require about 4 units of extra. Insulin will be required. So if he is going to take 1 vada also extra, so for vada, he will require about another 5 units of insulin. So it has to go 12.5 plus 9, he should take about 21 to 22 units for that breakfast. So this is how we have to calculate the insulin for that particular meal. It is all based on insulin carbohydrate ratio. Now the question is, we have understood what is insulin carbohydrate ratio. We understood how to calculate for that meal. So he has to see the meal and he has to calculate. So we have done that. So where to know how much, which food contains, what is the carbohydrate ratio, how to know that. So for that, we have already recommended you this book, which has got the carbohydrate content of all Indian foods based on their size, based on their proportion. So they threw the food in a bomb calorimeter and they were able to see what is the amount of energy, what is the amount of carbohydrate which was getting released from the particular food substance, and they have given the chart. Beautiful book which is a must read for every one of us. So which has given the carbohydrate ratio for various preparations. Or if someone is not okay with it, there is an app called as Healthify Me. So this also you can take. There are plenty of apps might be available. You also might be knowing other apps. So this apps, as you feed, like if you feed like coffee with half spoon sugar, or if you feed like 1 dokla, or if you feed 1 aloo paratha or 1 dosa. So if you feed that based on the size, approximate weight of the food substance, it will typically give how much amount of carbohydrate that particular food has got. So as we eat, the patient can know that the amount of carbohydrate that particular food has, and it becomes a habit over a period of time. They don't need to worry about every time feeding or taking this diet chart. They will know that is the amount of carbohydrate that they are consuming, and based on that they can correct their insulin for that particular meal. So this is what how the insulin dose has to be adjusted based on the carbohydrate counting. Now, having said that, this is the fourth point, how it has to be adjusted based on the carbohydrate counting. Now, it is all good. It will be all okay only if the blood sugar before meal is about, say, if the blood sugar over here is 140, if you are going to give that amount of insulin, it will work very, very fine. So, let us presume at 2 o'clock his blood sugar is about 200. Now he is going to take that biryani with chicken, for which we calculated he requires about 13 units of insulin. Now, the 13 units of insulin will take care of this biryani only. But what will happen to this 200? So, the blood sugar already, it has to be between 100 to 125. So, that is what the prandial thing that we need. So, how to address this? There is but blood sugar is about 200 now. So, there is already it is about 200. The blood sugar is 200. So, when you give 13 units, it will take care of the biryani. But in no way it will address this hyperglycemia which has happened over here. So, if it is 100 or 125, if you take biryani, after food, the blood sugar will be 140 to 180. It will be fine. But if it is 200, now again after food, it will be now 280 or 260, because as such, the baseline itself is higher. So, it is not going to get reduced. So, for this, there is something called as a correction factor that we need to give. What is correction factor? We will see this correction factor in inpatient management also. The next talk is going to be, the next module is going to be the inpatient management. We will see about this correction factor over here also. But what is important is this correction factor that we are talking about type 1 diabetic is, so this correction factor of insulin will bring down the sugar from 200 to the baseline, so that post breakfast also or post lunch also it will get corrected. So that is the role of this correction insulin. Say if it is if the prior lunch is about 125 or 130, even 140, we don't need to act anything on that. Just leave it correcting the meal related excursion. If it is not so, if it is already higher, if it is 180, say it could be even 250 over here. So if it is so, then you have to address for the 250. Then only the carbohydrate ratio will come down. So this is what we mean by correction factor. Correction factor will correct the already existing hyperglycemia in our patients. So how to go about it? So there is a calculated or scientific or systemic way how do we address this excursions which is happening. So for that we need to know something called as insulin sensitizing factor. The prior one is insulin carbohydrate ratio. Now we are talking about insulin sensitizing factor. So insulin sensitizing factor is the amount of blood glucose reduced by 1 unit of rapid or short acting insulin over a period of 2 to 4 hours. So this correction factor will act on this and will bring down this blood sugar to a level which is needed. So the insulin sensitizing factor will reduce the blood sugar. Insulin sensitizing factor is the amount of blood glucose reduced by 1 unit of rapid acting insulin over a period of 2 to 4 hours. So the amount of blood glucose reduced by 1 unit of insulin is, the rule is 1800 for an ultra short acting analogs. So 1800 divided by total daily dose of insulin. So how much does our patient take? We have 1800 divided by 60, which is about 30. So the insulin sensitizing factor in SAM is about 30. So the thumb rule is the insulin sensitizing factor generally will be between 50 to 60, or we can keep it as 50 is the insulin sensitizing factor for most of the individuals. But in the case of SAM, it is about the insulin sensitizing factor is about 30. So what do we mean by this 30? 1 unit of insulin will reduce the blood sugar in 2 to 4 hours by 30. So if you see in this case, if you want to bring down the 200 blood sugar to 100 or 125, we have to reduce at least 60. So for that, we have to give the patients 2 units of extra insulin. So if you give 2 units of extra insulin, it will come the blood sugar from 200, it will come to 125. So for 13 units of meal, 13 units for the chicken biryani that he is going to take, we have to add 2 units to this, which is about 15 units the patient needs to take, so that the glycemic excursion which was happening because of the meal would be addressed. So if it is say about 250, what will happen? So what is our target? So we have to bring it at least to 120. So which is about 130 milligram, it is extra. So we have to give 4 units extra. So 4 units of insulin we have to add to this. So if it is 250, then we have to add 4 units over here, which is about 17 units we have to give. So this is how the insulin sensitizing factor works. So how to know, how to calculate, or how to understand this insulin sensitizing factor, how to test for this insulin sensitizing factor is just to choose a random time of the day, whether this insulin sensitizing factor is working properly or not. Just to take a random time where the blood glucose of the individual is about 200 milligram or above. So that is the requirement. So, and also the patient shouldn't have consumed any food in the past 4 hours. So at a random time, when the blood sugar is about 200 and when he has not consumed any meal for more than 4 hours, then you give 1 unit of insulin. So what should happen? This 1 unit of insulin will correct the blood sugar by 30, okay? Or he can take about 2 units of insulin. Already we know by the insulin sensitizing factor how much it works. But whether it is working properly or not, how do we know? So give 1 or 2 units and see how much the blood sugar is. And also he should not supposed to eat for next 3 hours. Then he has to record, the individual has to record the blood glucose in the given table. So like as it has been given in this table, he has to record. So first day, say let us presume like 200, and his blood sugar after giving 1 unit, it is about 170 or so. So the next day again his blood sugar, it was about 210 or so. Then he has taken about 2 units. So when 2 units, if the blood sugar has gone to 150 or so, fine. So within 30 milligram per deciliter of the target blood sugar. So instead of here, we can instead of giving 2 units, we don't need to confuse much. Rather at this point of time, we can ask the patient to just take 1 unit alone. So for testing the insulin sensitizing factor and see whether the blood sugar is about 180 or so. Next day again he can check. So if it is within 30 milligram per deciliter of your target blood sugar. Why 30 milligram per deciliter of the target blood sugar? So that is what we anticipate in SAM. 1 unit will decrease by 30 milligram per deciliter. If it is decreasing by 30 milligram per deciliter, it is absolutely fine. If it is not so, then we have to change the insulin sensitizing factor. So if the blood sugar remains high, so instead of about 170, if it remains 180, or here if it remains 180, or in case if it remains 190 over here, so even after 3 hours, the individual is receiving little insulin from the correction bolus. Then we have to decrease the insulin sensitizing factor by about 20%. So that means that his insulin sensitizing factor should be from 30, it has to come down to 24. It means 1 unit of insulin will reduce the blood sugar by 24 milligram per deciliter. So that is what we need to know. So whether that is working properly or not, this is slightly a step ahead. So whether the insulin sensitizing factor is working properly or not can be known from this chart, where what we do, we take the patient, ask him to come, or the patient has to, on a random day, when his blood sugar is about 200 milligram per deciliter, he has to give only 1 correction dose and see how much is the blood sugar after 3 hours. In the meantime, when he has given that 1 dose, he should not consume any food. So if the desired insulin sensitizing factor is working properly, so if it is 200, it comes to 170. So that is what we anticipate. If it is 210, if it comes to 180, that is what we anticipate this in our patient. If it is not falling so, it means that the insulin sensitizing factor has to be corrected or decreased by 20%. So when we decrease it by 20%, instead of 30, the insulin sensitizing factor now comes down to 24. So when it comes to 24, it means that 1 unit of insulin will decrease the blood sugar by only 24. So over here, for the correction factor, for the same biryani, so if it is happening, so for 13 units which we have calculated for the biryani, and if you want the blood sugar now around 120 or 130, so how much has to be corrected? It has to be 70 or 80 has to be corrected. So 80 divided by 24 will be approximately 3 units. So he has to take about 3 units of insulin, so which is about 16 units for the meal. So this is how we can calculate the insulin sensitizing factor. So as the patients start practicing these 5 principles, they would be able to maintain their blood sugar. So the points that we have conveyed as for the type 1 diabetics are very, very clear, and there should not be any doubt. So just to work on these principles that we have told, just think about it once or twice how it works, and you will be able to adjust these doses in a very, very scientific way. So there is no role for premix insulin in type 1. It is all about basal bolus, and when it comes to the calculation of dose, it is about the requirement is about 0.5 units per kg, of which 50% has to go as basal and 50% has to go as bolus. For a given individual, it can vary between 0.4 to 1 unit also. The requirement it can go up to even 2 units per kg also. So the insulin requirement, we need to know how to split between basal and bolus. And the third point that we need to know is very, very important. The insulin requirement with the breakfast is slightly higher than the lunch part. So always, like, instead of, if a patient requires 8 units, it should not be 666, rather it could be 756 or 846. That is what we need to do. So slightly more than the lunch, the patient requirement for breakfast would be higher. So the 2 important concepts, though it might be little confusing, is first, the insulin carbohydrate ratio the patient should practice. So how much amount of carbohydrate they are consuming, and what is the amount of insulin that has to be given for that carbohydrate ratio. The 5th most important point is, once we have done the carbohydrate ratio, only if the pre-meal sugar is higher. That is what insulin pump also does. So in insulin pump, before putting any insulin, when we sensitize the pump to give the desired amount of insulin, but before that, we check the blood sugar for 2 reasons. We need to know what is the blood sugar before food, so that the sensitizing factor can be added. Second thing is whether the pump is working or not. So in case if the blood sugar is 400 or so, like, it means that the pump has failed. So we need to know before lunch or before dinner, before meal, we need to know the sugars. So once we know that, that amount of correction factor has to be given for the patient, that is based on insulin sensitizing factor. So insulin sensitizing factor, the number is 1800 for analog insulin. So just remember this 1800. Don't know for regular insulin and all. So that will do for most of our patients. So these are the important 5 principles that we need to know for our type 1 diabetic, for their blood sugar to get control. So with this, you can monitor 1 or 2 patients and understand. As you start gradually doing it, you will understand the skills which are required, and the patient also will feel happy once they are able to do that. For that, 7-point blood sugar is mandatory. So the patient should do 7-point blood sugar. It will take some time, but practice, it will give enormous benefit to our patients. So with this, we will conclude and move to the next session, where we will be discussing how to monitor the blood sugar in our inpatient setting. Thank you.